My dear students, in this video, I'm going to discuss a few things about the therapeutic vaccines. Although the therapeutic vaccines per se is not a part of the therapeutic armamentarium of critical care, but since this is a growing concept of growing interest and the subject is attaining considerable attention worldwide amongst the healthcare professionals, so preliminary knowledge of these therapeutic vaccines will be useful for all the intensivists like other internists. Let me start with a case as a prototype. A 75-year-old male with a history of type 2 diabetes presented with poor oral intake, general weakness, and significant weight loss, that is 15 kg over a course of 2 months. He also had persistent urinary frequency, incomplete bladder emptying, and nocturia for several years. A digital rectal examination revealed multiple firm nodules in both prostate lobes, and CT abdomen revealed 7.2 into 5.3 centimeter soft tissue mass in the pelvic cavity that involved the prostate gland and the base of the urinary bladder. The PSA values were more than 1,000. The MRI showed advanced prostate cancer 5.6 into 4.4 into 4.6 with extension to the seminal vesicles, bladder invasion, bilateral pelvic lymphadenopathy, and diffuse bone metastasis. Now, quite obviously, this is the presentation everywhere. It's of a CA prostate. Now, we all know that in CA prostate, other than surgery, hormonal treatment is the only option available, particularly in elderly patients. Now, is there any role of vaccination in this cancer? Now, for those of us who are curious to know, then the answer would be yes. And it would be good to know that this Sipuleucel T, commercially available as Provenge, it is an autologous vaccine which is approved by ADA for treatment of men with asymptomatic or minimally symptomatic castrate-resistant metastatic prostate cancer, which means that normally when a patient with a prostate cancer, we remove the source of testosterone by doing an orchidectomy, it is likely to respond. But in patients who are castrate resistant, in which simply removing the source of testosterone is also not going to affect or deter the cancer cells, this Sipuleucel T or Provenge is an autologous vaccine. So this vaccine, normally when we use vaccines, we want to prevent against a disease, but this vaccine prevents against future recurrences of prostate cancer. So Sipuleucel 2 is first in class as a therapeutic autologous vaccine approved for the treatment of men with asymptomatic or minimally symptomatic castrate-resistant metastatic CA prostate. Now, what are these therapeutic vaccines basically? Therapeutic vaccines or treatment vaccines are designed to treat or manage a disease rather than to prevent it. So they act by stimulating the immune system to recognize and attack specific cancer cells in case of cancer, infectious agents in case of infections, or other antigens in case of connective tissue disease, and either cure or change the course of the disease. They differ from other types of immunotherapies or targeted therapies, such as monoclonal antibodies, etc., because they provide active immunization by therapeutically stimulating an immune response. They are not immunomodulators, but they therapeutically stimulate the immune cells. They heal the immune cells, which otherwise cannot recognize these cancer cells, etc., to recognize them and enables them to recognize them and kill them. So immunotherapy is based on passive immunization because they transfer pre-synthesized elements of the immune system to the patient, and these pre-synthesized elements help the patient to fight their battle against the cancer or infection or autoimmunity, whatever it may be. But in these cases, they use the body's own defense mechanism, whom they train them, they heal them, and the body does not need to produce those elements on their own. So the therapeutic vaccines for cancer have certain mechanisms. It's only a basic idea of those are that there has to be an antigen presentation. That is, cancer cells often express unique antigens that distinguish them from the healthy cells. Therapeutic vaccines utilize these antigens to train the immune system to specifically recognize and target the cancer cells. Then the activation of the immune cells, that is, these vaccines can stimulate the activation and proliferation of the immune cells, which are essential for eliminating the cancer cells, like the natural killers, the CD18, and the memory response, that is, the therapeutic vaccines create an immune memory response and retains the ability to recognize and attack cells. So this provides them protection against future disease recurrence of cancer. So the vaccines can be made from the patient's own tumor cells or from synthetic peptides that mimic the tumor antigens. So largely, by and large, they belong to four classes: either peptide vaccines, genetic vaccines, tumor cell vaccines, and dendritic cell vaccines. The example that I talked about belongs to the dendritic cell vaccine. In dendritic, so all of them has their pros and cons. Peptide vaccines, they're cheap, easy to produce. They have long peptides. They provide personalized and semi-personalized warehouse for prevalent tumor antigens. They have high epitope concentration. Epitope concentration can identify the subtypes of the tumor antigens in detail. So these are all their pros. But if they're short peptides, then they have less than epitope cells, so they cannot identify the subtypes of those antigens. They are restricted to selected epitopes and they are of poor immunogenicity. So these are their cons. Likewise, with genetic vaccines, have some advantages that they induce humoral and cellular response. Their native sequence of protein and personalized therapy is possible. But again, the cons is that they have poor immunogenicity. For tumor cell vaccines, they also contain characterized and uncharacteristic tumor antigens, so they can identify even there is minor variations in tumor antigens that also they can identify, which helps them to train the immune cells against those particular cells. So, but they have poor clinical efficacy, and often the self or normal proteins in the vaccine pose toxicity risk. The dendritic cell vaccines are probably the best of the lot. They have all the epitopes available. They have measurable antigen presentation efficiency, but only problem is that they're logistically challenging, they're costly, and often labor intensive. So these are some of the advantages and disadvantages of the four different types of tumor vaccines. And bladder, breast, melanoma, prostate, cervical, brain, colon, and lung. These are the various cancers in which these tumor vaccines are being tried. And although limited success has been obtained, but at least a large number of trials are going on. Some of them are showing promising results too. So these therapeutic vaccines for cancer hold several potential benefits, like they can give targeted treatment because they specifically target cancer cells, sparing the healthy cells and thereby reducing the collateral damage in the form of side effects. They provide a personalized approach because they are personalization to each patient's unique cancer antigens and their subtypes. So this allows greater effectiveness or greater efficacy. Combination therapy, because used in combination with chemotherapy or immunotherapy, because they act as in synergy and that enhances their efficacy. And adjuvant treatment options. In many cases, the therapeutic vaccination presents an opportunity to improve or ameliorate disease or to prevent recurrence of the active disease. Yeah. So in herpes virus, there are several approved and effective prophylactic vaccination options, but those infected with HPV and HPV mediated malignancies, the use of therapeutic vaccines together with immune checkpoint inhibitors and adjuvants offer significant potential benefit, and these are which can be for the long run. So therapeutic cancer vaccines provide a targeted and potentially less toxic alternative to traditional cancer treatments. But there are problems and pitfalls of therapeutic cancer vaccines too, like tumor heterogeneity, cancer tissue being highly heterogeneous within a tumor, so they can vary between the patients. So developing vaccines that target a wide range of tumor antigens is challenging, so they will have limited efficacy. Immune suppression, because cancer cells create an immunosuppressive environment, so hindering the effectiveness of the therapeutic vaccines. Overcoming this immune suppression is critical for the vaccine. And third is the clinical trial design. Conducting rigorous clinical trials to evaluate therapeutic vaccine safety and efficacy is essential. And designing and conducting such trials is complex and time consuming. Most of the time, the clinical trials are inadequate or they are not so suitable, and adaptive clinical trials or platform trials are usually recommended for such type of vaccines. So therapeutic cancer vaccines may become a fundamental part of comprehensive cancer treatment strategies very soon. Let us see a second case. A 60-year-old female diagnosed with chronic hepatitis B virus and treated with pegylated interferon and ribavirin. Treatment was terminated after 3 months due to intolerance to ribavirin. She was started on a 24-week course of sofosbuvir and daclastivir. He was able to tolerate and experience severe nausea and constant retching, which was not controlled by metoclopramide. Her viral load was high even at the end of week 13. Genotyping demonstrated genotype 3A. Resistance testing revealed the presence of Y93H mutation and NS5A resistant substitution associated with resistance to antivirals. Now, is there any role of therapeutic vaccination? Now, even in this particularly hepatitis B virus, there is a role of therapeutic vaccine, and that has a potential to offer a cure for chronic hepatitis B. And currently, the Thervac-B is being passing through the clinical trial, and if it is efficient and passes all the clinical trials, it will have proven its efficacy to cure HBV, and the product is expected to be launched around 2028. So therapeutic vaccines for infectious diseases also identify specific antigens or proteins that are unique to the pathogen, and these antigens are then used to stimulate an immune response targeted against the pathogen. So they have been showing encouraging results in the treatment of chronic viral infections such as HIV, HBV, and hepatitis C virus. They target the viral latency, they harness the immune system to control the viral load, reduce the disease progression, and cause an overall improvement in the health. In tuberculosis, there is a significant opportunity to apply therapeutic vaccine as an adjunctive treatment or to prevent relapses. So, vaccine treatment approaches in infectious disease have the potential to make a significant global health impact in the near future. But again, there are certain problems and pitfalls of therapeutic disease, infectious disease vaccines because of lack of ability to elicit a strong, specific, and sustained immune response, as the immune system may be compromised by the infection, making it difficult to mount an effective response. And secondly, the high mutation rate of some infectious agents like HIV that can pose a problem in developing vaccines that can effectively target the evolving strains of the virus, because the future belongs to the evolving strains, not to the past strains. So clinical trials are being conducted to evaluate their safety and efficacy, and ongoing advancements in the technology have the potential to further enhance their effectiveness. The third case, this is a 50-year-old female with a history of mild and well-controlled hypertension, develops a right upper and lower extremities numbness 2 weeks after viral illness. Neurological examination shows right-sided sensory impairment with loss of pain and temperature feeling at the level of the C5 vertebra. MRI brain and thoracic and cervical spine identifies severe demyelinating lesions with enhancement in the subcortical region of the right frontal lobe. The spinal cord imaging showed an enhancing lesion consistent with demyelination at the level of C4, C5. The CSF analysis shows moderate pleocytosis, elevated IgG index, and the presence of oligoclonal bands. The diagnostic tests for infectious disease were negative, and the final diagnosis, which was clinched after all these investigations, was multiple sclerosis. Now, any role of therapeutic vaccination? Yes, there is, because although the current disease modifying treatments have demonstrated clear efficacy, They come with significant and sometimes life-threatening side effects and generally delay but do not prevent the disease progression. Several phase 1 and phase 2 trials have demonstrated currently the safety and feasibility of therapeutic vaccination strategies for multiple sclerosis, and it can be envisaged that antigen-specific therapeutic vaccination will prove to be highly relevant, especially early in the course of the disease. Now, the potential benefit of therapeutic vaccines in treating autoimmune diseases lies in the restoration of immune tolerance and rebalancing the immune system. Unlike the traditional products, they are distinct or designed to target specific self-antigens that are involved in the autoimmune response. And by inducing a targeted immune response against these self-antigens, the therapeutic vaccines modulate the immune system and restore its function. So, therapeutic vaccines for autoimmune diseases potentially provide targeted and personalized treatment options. Now, how does therapeutic vaccines act in autoimmune disease? They help to induce immune tolerance by promoting the generation of regulatory T cells, that is the Tregs, and by promoting the Treg expansion and activation. These Tregs are crucial in suppressing the immune responses and maintaining the immune balance or the immune milieu. So there are antigen-specific immune modulation and immune system reset. In antigen-specific immune modulation, the therapeutic vaccines aim to redirect the immune system's attack away from the healthy tissues and the healthy cells. And in immune system reset, this involves the use of immune modulating agents to alter the immune responses and restore the immune tolerance. That is, recognize self-antigens as harmless, because that is where the fault lies, and that correction is built up. So, therapeutic vaccines for autoimmune diseases potentially provide targeted and personalized treatment options. Now, what are the challenges with these vaccines? Now, identifying suitable antigens, self-antigens, ensuring vaccine safety and efficacy, and optimizing vaccine delivery strategies are the common challenges. But the therapeutic vaccines have the potential to provide long-lasting disease control if it can overcome these challenges and reduce the reliance on immunosuppressive medications, which we all know quite knowingly have a lot of adverse effects. So these are the various infectious diseases: COVID-19, HBV, HIV, and HCV, and the chronic communicable diseases like cancers, cardiovascular disease, respiratory disease, diabetes, Alzheimer's, dyslipidemia, asthma, COPD, and pulmonary disease, where a lot of research with therapeutic vaccines is currently ongoing. And if you look into the market, you will be finding that the CAGR is expected to rise by 26.63% from what it was in 2022 to what it will be in 2029. And almost all the key players in the industry are putting their money on the therapeutic vaccines. If you see the regional analysis, in North America, more than 50% of the product segment review showing an expansion, and followed by, of course, Europe and Asia Pacific. So this Provenge, which was developed by Dendreon, is the first therapeutic vaccine which was approved by FDA in 2010. And you have to remember that this first, it was vaccine, the therapeutic vaccine, Provenge, which was approved, it was after 25 years. Almost when the company was about to shut down, they demonstrated benefit. And after that, it took a splurge. So there are 3 cancer therapeutic vaccines which are approved by the US FDA so far. One is this Provenge, that is cycleucel T, which are dendritic cell-based vaccines for prostate cancer. Another is the Bacilli calmette guerin, that is the BCG or the Therasis, which is a live attenuated vaccine which makes use of Mycobacterium bovis strain for bladder invasive cancer, and also the Talimogene larypipe, that is the TVEC, or the Imlysic, which is a vaccine for advanced oncolytic melanoma. And currently there are about 369 cancer vaccine studies which are ongoing all over across the world. So what are the unique features of these trials which are being conducted on therapeutic vaccines? Now, this patient population is often more diverse with varying disease stages, treatment histories, comorbidities, and immune profiles. In therapeutic vaccine trials, all patients receive standard of care and the vaccine's efficacy is available in combination with existing therapies. The primary endpoints are often focused on clinical outcomes. The personalized approach requires careful patient selection, vaccine design, and monitoring to ensure optimal treatment outcomes. They often require long term follow up to assess the durability of the immune response and the vaccine's impact on disease progression and recurrence. And safety monitoring is crucial, particularly when combining vaccines with other treatments. So, the final take home message would be that therapeutic vaccines are an exciting area of research that has the potential to revolutionize the way we treat diseases. By harnessing the immune system to recognize and attack specific cancer cells, infectious agents, or self antigens, these vaccines offer a personalized approach to treatment that can drastically prolong patients' life and also improve the quality of life, bringing down the other drugs. So for the most part, therapeutic vaccines still are in the preliminary stages of development, but they're going at a very rapid pace. And no doubt that very soon they will make a huge impact in the medical care. Thank you very much.